Welcome, everyone. Welcome to this month's Health System Performance Network Ontario Health Team webinar. We welcome you to join us. And first, we always like to start off our webinars by getting to know each other. So I will ask you now to go to the chat box, open up the chat box on your screen, click on that box and go in and enter. Make sure you say to panelists and all attendees and tell us who you are, where you're from, and say hello. Welcome, Raju, from downtown East. Maggie from Niagara. Kate from Chatham, Kent. I love it when I go so fast I can't see. Messina, Frank, Kathy, Laurel from OHT Northumberland. Deborah from Pickering. Helen Lung, welcome Helen. Nice to have you with us today. Talking about population health. Sharada Weir from the OMA. Sandra from Muskoka area OHT. Lembrina from West Neighborhood, welcome. Catherine from VHA Home Healthcare, Western York. Martina from East Toronto, I believe. Okay. Amber from Western OHT. Welcome, everyone. We're so happy to have you here with us today for our webinar on Ontario Health Team's Population Health Management. And it's really great that we get to come together like this. And I was talking to a colleague in BC and she says, how do you get so many people coming out already right now? We have 242 people online. We're expecting a few more today. And last month, you may know, we were past 500. And I said, I think they come for the content, maybe a little bit of the show, and they stay for the chat. So again, today, I encourage everybody to be live and active in the chat box so we can learn about what you're doing and you can learn from each other about how you're thinking about this challenge of population health management. Welcome here today. I would like to acknowledge I'm speaking to you today from the University of Toronto, and the land on which the University of Toronto operates is, for thousands of years, has been the traditional land of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. We acknowledge that Canada is home to many diverse First Nations, Inuit, and Métis people, and many of you are joining us from one of those many traditional and treaty territories today. And we've spoken to you on those different lands. So welcome today to our OHT. And we're going to start off right away, just getting a sense of how many people are here for the first time, or have you been with us before? So have you joined us for an HSPN webinar before, or are you here for the first time? Please click into the box and let us know. We're counting up the votes. They're coming in fast. Everybody's getting quite handy with these days, very fast. And click in. I'll leave it up for just a few more seconds. Some people, I think, on their little phones sometimes have difficulty getting to the windows, but we have now over 80% voted. So I'm going to close this off. Last few people wanting to get in. There we go. Okay. And we're going to end it. And this is always, I find, quite interesting. So we have 170 people have been with us before, and for 53 people, this is your first event. So welcome, and you're in for a treat today. I think you're going to have a very enjoyable time, and I'm sure you'll be back for more. And I see that we're now past 275 people here. So welcome, everybody, and really glad that we can have you here with us today. Today, I'm just going to play host. I'll do a little bit of an intro, but we have a fantastic lineup today. One thing that I'm very proud of is with the Health System Performance Network, we have a trainee group. students that work together on issues related to health system performance. And they've been working very hard over the past year to preparing the materials that we're sharing today. And the reports, 3 white papers that we're soon to be releasing that are the background. So first, you'll hear from Lauren Tessier, PhD student, then Moody Kato, who's studying bundled payments for heart failure, COPD, chronic conditions, Dr. Daniela Weir, doing a postdoctoral fellowship with us at the HSPN and also at Trillium Health Partners. And then we have a very special treat. Some of you may have already met Dr. Rob Reed and Mike Hinmarsh through their work with RISE and their support of population health management in Ontario. And just to note, you're going to hear as we talk along the way today about Kaiser, and Rob and Mike both have a history with Kaiser, and I wanted to mention because they are experts coming from one of the foremost systems in the world. Behind the scenes, we have a great team of people who've been working. These are all the trainees and co-authors of the 3 white papers that we'll be presenting for the first half of today, and then we're going to turn it over to Rob and Mike to hear about how do we actually practice this in Ontario, and how are we able to support Ontario health teams. Agenda, I'll do a quick overview and takeaways in just a few minutes, and then we're going to go through our 3 white papers, 1, 2, and 3 on population health management, specifically a paper on segmentation tools. We're going to give you a pretty high level overview of these, and we'll invite you as soon as we can release these onto our website. They're forthcoming very, very shortly. We're just looking at the final versions now. And finally, real world applications. And then the application and implementation in Ontario, and that's what Rob and Mike will lead you through. I'm going to start with a definition of population health management that we have landed on for our uses. And that's the concept of gathering data and insights about population health and well-being across multiple care and service settings with a view to identifying the main health and social needs of the community and adapting services accordingly. And this is a long phrase and gathers both data and health planning and understanding that it is both about care and social services in people's health. And that's what we're trying to maximize. So this captures many of those aspects that we're very interested in. So what are the steps to population health management? So a comprehensive model, first promoted through the Population Health Alliance, would say that these are the 6 steps: population identification, health assessment and quadruple aim assessment, risk stratification and population segmentation, patient-centered interventions, impact evaluation, and finally, quality improvement processes. And we adapted in our work an adaptation to this promoted by Jeroen Struijs from the Netherlands, where they have been doing quite a bit of work in population health management, where they work through these steps. And this is more of an analytical framework, though, and allows us to say how well are people doing on their implementation of population health management. And we're going to focus today about risk stratification and population segmentation and how that fits into the bigger picture. And why have we done that? Well, first off, we're saying that OHTs already have an attributed population, so we're not going to talk about how do you think about that population. And we, as last month, we were talking about quadruple aim assessment. So we're going to be undertaking that, and we're going to be back with results in the future. So the next step for us to talk about here is this risk stratification and population segmentation. So that has led us here today. How is this segmentation realized? What is it about? Well, we can think about, that first definition talked about bringing data in, and that data can be quite useful in descriptive and also in predictive ways. And we also want to make sure that that data represents patient needs in a heuristically meaningful way. And that really leads to this bouquet of flowers. Picture those flowers as having many colors or many different kinds of flowers. And each flower deserves its own kind of care. And you can have multiple kinds of flowers that are the same. So that happens as well. And that really drives what that frontline application and service delivery needs to be. And that, in a nutshell, is realizing segmentation. The key takeaways for you to come at it today, and it's going to be a challenge. So somebody has sometimes asked us about, oh, there's so much information coming. Can you distill it? Well, we will, but you'll still possibly be a little overwhelmed today. You can go back and watch again in the future. We have most of our videos, many of our videos have now been watched over 100 times online after the events. Population health management is multifaceted and it's complex, and it has these two views, and you're going to be challenged today with both views. First, a macro view of the health needs of an entire population. You can think about that as across your entire OHT attributed population. What are the needs of that population? And at the same time, right now, you're focused on very micro precision implementation of appropriate interventions to meet the needs of specific segments of the population. Many of you have chosen, all of you have chosen priority populations, and that's your focus now. So you need to have that focus on how do you deliver excellent care to those individuals while still thinking about the broader population. There are some excellent examples of population health management around the world, and we're going to talk about some of these, but know that everybody, even if they've been at it for 15 years, they are still working on it. This is a journey we are embarking upon. And that population health assessment and segmentation, it's an essential tool. It's not the only tool, but it is an essential tool. Finally, the OHT is building population health management capabilities over time that you will then apply to different segments and populations and subpopulations. And I think that's how Rob and Mark are going to position this. And I already see people hopping into the chat. So Marjorie, I see pointing in there some comments. So keep that alive. I'm really looking, and we will continue to bring voice to the chat along throughout today's presentation. So we have 3 white papers coming out, population health management in 3 parts, and we're going to go through each of these now. And I'm going to call on Lauren Tessier to lead us off through the first one. I'll continue to run the slides for you, Lauren, just to keep things simple.
Okay, good afternoon, everyone, and thanks again for your participation today. So as Walter noted, I will be presenting on an environmental scan we conducted to understand current approaches to population health management. So just moving on to the next slide, outlining the purpose of this work. So we had 3 main goals. This was to understand the descriptive and contextual characteristics of existing population health management systems, to ascertain whether these systems are effective, and to determine what can be learned from the experiences of other jurisdictions implementing population health management approaches. So moving on, how did we do this exactly? We selected 5 case examples of population health management systems, 2 being country-level undertakings, while 3 reflect regionally driven initiatives. The systems were selected for variability in geographic location, level of maturity, and political and health system context. We then used the Population Health Alliance analytic framework that Walter described to structure a review and description of the systems. We really focused on trying to capture the key contextual and organizational characteristics of each. And then from that, we were able to pull key insights for Ontario based on the strengths and learnings from each system. So we'll start with maybe the Mecca, perhaps the system that most people know the most, Kaiser Permanente, specifically its Washington division. So probably just for a bit of background here, the most important thing to know about Kaiser is that from its outset, it really has put integration at the core of its organizational ethos and has therefore adopted a series of integrated care principles, including physician accountability, a collaborative multidisciplinary workforce, cost effectiveness, e-health investment, and integration of the patient's viewpoint. And it's with these integrated care principles and this history of integration in general that Kaiser Permanente's Washington division launched its population health program. So the key takeaways from Kaiser's foray into population health management, first and foremost, are really their substantial investment in e-health. So over 10 years, they spent approximately $4 billion on their EHR Health Connect, which is interoperable across care settings, including inpatient, outpatient, and clinical support, It has connectivity to laboratory pharmacology and radiology systems, as well as a web-based client portal for secure patient-provider messaging and access to personal health records. There's also a system for messaging between providers. So it's very comprehensive. And another noteworthy feature of this system is that their segmentation approach is critical to both the organization and delivery of the programs they deliver through their population health management initiative. And the segmentation is reviewed and revised on an annual basis. Okay, so moving on to Germany, Gesundes, Kinzigtal, and I'm sorry for my pronunciation. So Germany has a mandatory health insurance model, which combined with legislation, allowed for an integrated system to develop. So GK was created in 2005 as a contract between a regional physicians network and a management company specializing in integrated care. Two statutory health insurers were also contracted as part of the model. It targets the entire population of the Kinzigtal region of southwestern Germany, which is approximately 71,000 people, but individuals do have to opt into the model. So as of 2016, it covers approximately 33,000 enrollees. External and internal evaluations have demonstrated improvements in health outcomes, most notably lower mortality rates. Improvements in efficiency, experience of care, and cost savings have also been demonstrated. So key takeaways from the German context really are that from the beginning, they were guided by a policy framework during the development and implementation of their population health management system. Importantly, they also had a dedicated design and implementation team, along with startup funding, to support readiness, both cultural readiness and informational readiness. And I think this early focus on implementation support really is noteworthy, as it has been shown that up to 70% of implementation efforts can fail as a result of the implementation setting not being ready. Moving on to Sweden now, so Jönköping County Council. Sweden has a population of approximately 10.3 million people, and this population is divided geographically into 21 county councils and 290 municipalities. Healthcare in Sweden is almost entirely publicly funded, though the county councils exist and are responsible for regulating pricing of both public and private fees. The Jönköping County Council integrates public health, primary care, hospital care, and social care to serve a population of approximately 340,000. So our key learnings from Sweden are really that their foray into population health management, similar to Germany, were really first made possible through federal level governance supporting an integrated care approach. Just as critical was the establishment of an organizational infrastructure to support continuous quality improvement. And closely related to this was the establishment of the data and IT infrastructure that are needed to support quality improvement. And overall, really just to drive the point home, it really is this focus on quality improvement that both encourages and supports the ongoing innovation and evaluation needed to effectively manage their entire population. Moving on to the Netherlands now. The Netherlands is a particularly interesting case, and this is kind of where we start to move into systems that are slightly more comparable to Ontario's context because they still are in development. So in 2013, the Netherlands Ministry of Health, Welfare and Sport designated 9 regional innovation initiatives as pioneer sites in a nationwide effort to achieve better healthcare at lower cost. These sites serve more than 2 million people and represent partnerships among providers, insurers, and other stakeholders. And they are currently implementing project plans to accomplish the triple aim through the integration of clinical and community services. So the key takeaways here is that despite starting in 2013, they don't yet have hard evaluation outcomes. So in other words, they as of yet have not seen significant movement in their priority populations. And this really shouldn't be taken as a failure or as a bad thing, because they really have taken a developmental evaluation approach and they've really tried to integrate learnings as they've gone along. In 2017, a qualitative study based on interviews with 63 stakeholders involved in implementation within the 9 pioneer sites found three really interesting takeaways, and these were that trust is critical to the type of health system transformation that population health management approaches require. So thus far, the pioneer sites have really pursued small scale interventions that foster collaboration between insurers, healthcare providers, community services, and community representatives with the aim of improving the underlying relationships amongst these different stakeholder groups. And the other two main findings were that fee-for-service payment and funding models inhibit integration, and that political and legislative support are required to support the health information needs of population health management approaches. And finally, we can move on to Singapore. So in 2008, the Singapore Ministry of Health created 6 regional health systems with the goal of delivering more comprehensive and integrated care. In this model, each of the regional health systems was responsible for a specific geographic region, where the goal was to apply a population health management approach. And in 2017, the 6 regional health systems were collapsed into 3. So once again, the Singapore system is still in development. And key takeaways here are that first, this was really a top-down transformation. The ministry provided high-level funding and oversight, and they also determined the priority areas for the population health management initiatives. Hospitals initially played a pretty significant role, but this kind of undermined participation from community from the community care sector, which generally had less funding that was failed to be addressed through the population health management initiative. So this imbalance did make it hard for hospitals and the community and primary care sectors to collaborate. They did establish a national EHR system to support their population health management initiative, but there has been issues with this system. And finally, innovation and funding and remuneration in Singapore has been limited, and this has compromised the success of related programs. So overall, this has been a lot of information, but important key takeaways are, I think, first and foremost, that it is really important to take the time early on to focus on building trusting relationships between different organizations and different groups of providers. Again, because this is a very long-term transformation of the entire system. Very closely related to that is that built-in quality improvement culture is also critical to long-term success. And as Kaiser has shown, population segmentation plays a critical role in both the organization and delivery of population health management. And really having that IT infrastructure to support such an EHR long-term is also necessary. As we learned from Singapore, increased investment in primary and community care are also necessary, but this must also be complemented by ensuring certainty in payments for hospital providers during the transition to a greater focus on community-based care. And then finally, innovative funding models that allow for shared accountability truly are necessary. And that's it. Thank you so much.
Wow, thank you so much. And I had put out quite a challenge to Lauren, and I said, can you do this in less than 15 minutes? Because I'll tell you, it's our report's about 30 pages long and has a lot of tables of all of the context of these programs, and also some of the details of these pieces. Great job. Okay, I've got a couple of discussion questions here, and I'm going to come up to the chat because already people have been chiming in with some questions, some comments, some suggestions. We like to see all of these in the chat box. So interested now in hearing a little bit about what you found most interesting among the programs, and if you think would be hardest to replicate. To see some comments upside about IT. Maybe we'll get to some of those. And what do you think sounds interesting and that you'd want to learn? So let's just have a look at some of this chat. I'm going to leave off that part for now. Coming back a little bit, we had a question early on around having IT solutions. So, let's continue to have this discussion. I actually have a question for you later in this as to whether it makes sense for people to develop their own solutions, or should we be thinking about common provincial solutions? When we've seen these programs, they have often been within subsystems, and they've just gone ahead because they didn't have necessarily a national imperative, or if they did, it didn't come with infrastructure and data systems. You'll hear later on about Northwest London, where it's an example where there are pioneer integrated care systems across the United Kingdom, and they all have a very strong information record, but it's not in a shared place. And so they have had to create their own form of sharing, but that's not replicated elsewhere easily. So that's a good question for us to battle with. And I think there was a question, and we're going to come back, and I know that we have other panelists, and we're not going to bring everybody onto each chat point. But there's a question around optimal size, and Miro Shannon had the question about seeing, even in the Netherlands, with only, I think, 14 million people in the Netherlands, they have they have their country divided into regions, and that brings with it, how are they working within those? And I think the balance that has to be struck is to have national programs and campaigns, and healthcare is local, and it's developed by relationships. And so I think they're really trying to foster those integrated delivery systems and relationships locally. And then the question is how do they provide a bit of a backbone nationally to have that same common interest? And so then the sizing of that, and I think the sizing becomes particularly important, that probably small is good when you're trying to build relationships. But if you're going to take on financial accountability, you need to have enough people that you can actually talk about risk sharing and having risk mitigation for those people who are outliers. Okay, there were some questions around faux engagement, and Kelly Kay had a suggestion about creating interprofessional teams that serve faux physicians to care for segmented patient populations, for example, those living with dementia. So there are ways to engage physicians, which are quite an essential component. Will we be sharing this? Yes, you will see up on our website very soon 3 white papers. We will announce it to everybody so that you don't miss out on the white papers as soon as they are released on our website, alongside these materials and other materials that we've been putting out. Yes, being, I think there's some comment here around from Nasha Badugani around having a true integrated clinical system being part of a provincial mandate, and integrated clinical data being essential. Alan Katz, that's just a compliment. Trust is fundamental, and funding formulas inhibit integration. Our current funding formulas very much inhibit integration, and needing to think what those should look like outside. Yes, Anne-Marie Yerskevich, interesting common thread continuing about building trust between providers in early days and how to do that. And in this talk, that came out of our Netherlands example, and there's a beautiful Dutch phrase that says, trust comes in on the back of a turtle and leaves on the back of a horse. So that the Dutch think about trust and the ways that it can be enabled, I think, very, very much. And I see that some people talking about the massive amount of investment that might be required by some systems. So Kaiser didn't put all that money in on day one. They put in a lot on day one, but they've also evolved that funding over time, over a decade. So IT is also not a stagnant piece. Things need to move on. Sometimes we're seeing people are chatting in comments just to the panelists. Please do be sure that when you send your notes, it goes to panelists and attendees, because this is really a conversation. And we're already seeing if you do that, you get some resources back from the other attendees. So I'm very, very happy to get this started. And Lauren, thank you so, so much. And we're going to turn it over now to Moody to talk about the rapid review that their group led on population segmentation tools. And this was around talking about using the data to create the segments. Go ahead, Moody.
Good afternoon, everybody. Thank you so much for joining us. So today I will be talking, as Walter mentioned, about a population segmentation review. And we wanted to see what the literature told us about population segmentation, the tools, as well as how they would be applied to Ontario health teams. So the purpose of the population segmentation review was to describe the different approaches to the segmentation, as well as to contextualize how the segmentation was applied. We also wanted to capture the data sources, the different variables or the features that were used to drive the segmentation, as well as the methodologies used to develop population segmentation. We wanted to assess the actionability or how these results were used by the different target audiences as well, which is really key for clinicians when it comes, as well as policymakers. So in terms of our methodology, this was a rapid review. We searched PubMed, CINAHL, Embase, Scopus, Prospero from 2015 to 2019. Some of the key terms that we use included population, segmentation, tools, population management. We included articles if there were full text original studies, the segmented population for population management. We included them. The segmentation was undertaken through a data-driven approach. So that is using empirical data. And then we also wanted to make sure that they use clinical judgment or risk assessment or a combination of these approaches. So the data was abstracted into 3 different categories, and this included some of the basic characteristics of the study, the population health application, as well as the data content of the segmentation tool. Moving along. So our search yielded about 2,000 citations from the 4 databases that I mentioned. After removing the duplication, we ended up with about 1,166. And after screening for the inclusion-exclusion criteria, we ended up with about 93 full-text screenings. Also, I just thought it'd be important to note that we included 4 different studies that conducted a similar review and looked at the articles that they cited as well. And once that was done, we ended up with about 360 full-text studies. And after reviewing all the text, we included 25 articles for the purpose of this review. So in terms of the kind of data that we collected from the review, we looked at the study characteristics. So we wanted to understand what their study population was, the types of data sources that they use, what types of methodologies and techniques did they use to actually derive these segments. What was the tool used for? Who was the end user of the tool, as well as were they able to capture different dynamic changes in the population? Some of the operational characteristics that we looked at included how many segments were included, what is the outcome of these segments, the purpose for the segmentation, and how this information was delivered to the end user. As I mentioned earlier, the actionability of the segments was also quite important to us because we wanted to know how these results were being used. And finally, in terms of data content, so what types of variables and features were used to derive these segments? So we looked at the health status, the sociodemographic characteristics, healthcare utilization, things such as diagnostic procedures, as well as whether variables such as health equity adjustments were made to the segmentation. Moving along. So Walter actually had quite an interesting analogy when he talked about the different roses, when he talked about the bouquet of flowers and how this relates to population segmentation. In this particular image, you see roses, and in other instances, you might also see lilies. But really, when it comes to segmentation, you need to treat a rose the way you would need to grow a rose, and the same thing with a lily. But I guess what we're trying to say here is that every segment is very much unique to itself and very different. Segmentation facilitates the development of services that are based on common sets of needs that are associated with each segment. So once you understand the distinct need of population segments, it might actually facilitate the identification of maybe unmet needs. You can also compare services recommended to an individual in a segment with the typical services that they would receive in that specific segment. Moving along. So what were the different approaches used in the segmentation? So there were two types. There was data-driven approaches as well as clinically driven approaches. Data-driven approaches employed a post hoc statistical analysis. So you might hear things such as cluster analysis, latent class analysis. And what it is basically statistical analysis that have been applied to empirical data to segment a population. Some of you might have heard of the term ACGs. And in this case, an example is in Spain, they actually applied ACGs in 13 different health centers in Catalonia. And what they did is that by applying ACGs, they were able to examine different clusters of patients, as well as look at the relationship between the burden of disease to the healthcare utilization and cost of care. So when it comes to clinical oriented tools, a lot of the times the studies looked at classifying patients based on illness or healthcare needs. So one of the examples is in the Netherlands, in northern parts of the Netherlands, they segmented patients that were older than 65 years old. And the goal was to develop segments of older adults based on the elderly population's needs. So they looked at things such as frailty, functioning, and other biopsychosocial needs. And the segments helped them identify the extent in which their needs were being fulfilled. Moving along. So we wanted to understand, I guess, based from this review, what kind of recommendations we could provide to the OHTs. So understanding that Ontario is very much rich with linked population admin data and claims data is something that is quite, it's an advantage because a lot of this data can be used for population segmentation. OHTs should consider both data-driven algorithms as well as clinical approaches to assess the relative merits of each. So whether it's data-driven or clinical, as well as the potential for transitioning to a potentially need-based approach to care. So future explorations of data-driven approaches can also be done. So an example of this would be using machine learning or other types of statistical techniques to be considered. However, it's important to note that these types of techniques tend to lack important considerations, such as linkages between patient groups and the types of care that they may receive. It's also important to ensure that a need-based approach is implemented in order for there to be population health management. And the goal is to align clinical care with patient-centered interventions.
That's great. Super. Thanks a lot, Moody, for leading us through. And the chat's been quite active on the side. I've been trying to respond, and others too weighing in, Kay and Lauren. So thanks to the panelists for weighing in. We are going to just put up another poll here, and I would be interested in knowing when you were thinking about your populations about a year and a half ago, some of you just a half a year ago, you had different sources of information. What were the primary sources that you used in selecting your priority populations? And it may have been more than one, so be interested to see where you really drew from in creating and identifying your own populations. And we have 60, 70 people. So think about that. This is probably some people maybe not directly attached to OHTs, may not have an answer, so we'll probably cut this off because everybody here is not in an OHT. So I'll leave it up for about another 10 seconds. More than 100 respondents now. We have, we're up to 328 today joining us from all over Ontario. Thank you all for joining and for bringing in your ideas into the chat, because as I say, you know, it might come for the content, but stay for the chat because that's where the action is. We're just the window dressing up here sometimes. Okay, I'm going to share out the results right now. I'm actually quite happy to see people using your own data in many of the cases. It looks like 69%. Again, these will add up to more than 100 because people used multiple sources. Ministry data package, also very common. Prior experience, people bring in their knowledge, clinician advice. And for a few people using other, I ask that maybe you can also chat in your ideas about other things that we don't have on this list. I was trying to keep the list short and brief for the purposes of the poll. But I'd be happy to hear what people are doing in the chat. I'm going to take maybe a few seconds now and think about, how people should be thinking about population to segmentation. Do you think that everyone really chose their own initial populations themselves, and that could be done, but you had to sort of do the work yourself a little bit? And with limited data, I've seen some chat back and forth about what data people have access to. So partner data, community advice, other sources of data coming in. Thanks Marjorie Conan and William Homerston for making those comments in. And then Dania Versailles, the selection of a second population brought by the COVID-19 mental health and addiction sector. So very interesting having different people come in and share their specific view. So now to this question, having a common data set, we need to have common segmentation print practices. And knowing Laura Visser commenting that the data-driven approaches are only as strong as the source data. Key population health considerations that are not captured widely around particularly needs with people with disabilities. And I saw a comment earlier around similar, and it was Nasha Batagani commenting that the groupers focused on clinical diagnoses because they draw from clinical billing data often and not some of the underlying factors that influence health. And we looked hard, those data-driven approaches very rarely, and you'll see we do include in our tables whether they had incorporated measures of equity. Specifically, we were very interested in that, whether they had other dimensions of health other than the clinical diagnosis. So we do for the 25 tools, and you'll get a bit of a sense of what was available. I think many of them were driven by data scientists who are interested in the data more than the use of the data. And so I think it's important for us as we think about population health management and identifying risks that we are cognizant of the wide array of data that we can bring in. And if we only look under the streetlights where it's easy, we're going to have a limited view. And to follow the lighting allegory, maybe we need to find some flashlights to look in the corners and find some of the needs. Also a discussion coming, Melissa Sharp-Harrigan responding to Neil. Sometimes provincial data is not an accurate reflection of local experience. So that's so true. And as we've said along the way, we are, as a group supporting evaluation across the OHTs. And last month we were talking about some indicators, and next month we're going to be bringing back some data that are common across the OHTs. It is such a limiting view that we can have into the work that you are doing. And that's why we encourage you to think locally about evaluation in putting in your perspectives. And okay, other comments, last few I will pick up. Lorraine Sundstrom, not all healthcare provided by the Ministry of Health funded organizations and without the full spectrum of local community providers, significant lack of the full picture. Very true. And we need to think about bringing those in. And this might be a place where it might be easier to do that locally, or it might be easier to do that provincially. And I think that's probably where we need to have a deeper discussions about how can you bring different data together, and ideally individually at the different levels. So it's a good thing to strive for, to have really useful insights. And I think also being sure that we are bringing patients and caregivers along to understand what's important to them as part of this discussion. So I will raise that point a little later. And okay, so the last part of their three-part report is on real-world applications. And so I am going to invite Daniela to join us now and talk about our practice-based review on real-world applications of population segmentation.
Thanks, Walter. Hi, everyone. It's a real pleasure to have the opportunity to present the results of our practice-based review today. So the purpose of our practice-based review was to describe how population segmentation is actually practically applied in healthcare systems. So you can see our report below, which will be publicly available shortly on the HSPN website, and you can see all the detailed information that this presentation is based on. So just to give a brief overview of our approach, we selected case studies for our review based on health systems that were actually using population segmentation in their population health management approach, as well as those that provided descriptions of their segmentation methodology within publicly available documents.
Hey, Daniela.
Yeah.
Just some people hearing, finding it a little hard to hear you. So if you could get a little closer to the mic, thank you.
Sorry about that. Is that better?
Much better.
Okay, sorry, thank you. So we also conducted interviews with key informants from each healthcare system to augment this publicly available data on segmentation, and in order to gain additional insights into the application of population segmentation in practice. So we selected three integrated care systems as our case studies. These included Denver Health in the US, Kinzigtal in Germany, and Northwest London in England.
I'm going to call you on your mic again, just a bit closer again.
So overall, we found that the leading healthcare systems across the globe are currently implementing population segmentation and population health management, and that population segmentation can be used to improve quadruple aim goals by informing funding levels, enabling health and social services to be targeted to patients according to need, and by identifying social determinants of health needs and population health promotion activities. So our first case study was Denver Health in the US. So this entire health system uses a common electronic health record through Epic, which enables real-time and comprehensive cross-system sharing of health information across healthcare providers. So interviews with representatives from this health system emphasize that clinical interpretability of population segmentation was really important in their setting for provider acceptance and adoption of segmentation for care delivery. And that identifying patient needs is only useful if programs actually exist and are available to address these needs. So this figure provides a visual representation of Denver Health's overall segmentation and population health management approach. The left triangle shows the population segments, where tier 4 is the highest risk group and tier 1 is the lowest risk. The orange arrow specifies the cost associated with each tier, and the right triangle and arrows outlines the staffing models and the health services targeted to patients within each segment in order to meet their specific needs. So each of the case studies we're presenting follows their own approach for segmentation and targeting of health and social services, but they each follow the same general framework as the Denver Health model here. So our next case study was Kinzigtal. So this health system developed a really strong integrated health information system with interoperability and the ability to alert providers regarding their own patients' risk. So similar to Denver Health, provider acceptance of risk classification and the adoption of segmentation for care delivery was highly dependent on clinical interpretability. Additionally, community level population health activities, such as outreach clinics with nurse assessments and linkage to social services, were important in this system for addressing the social determinants of health. Our last case study was Northwest London, which has access to comprehensive health and social care data within a central repository. So this system uses dashboards to visualize entire practice populations and enables selection of patients with particular healthcare needs. This approach has high clinical validity. However, this dashboard is separate from the patient health record, which is a reported barrier to its use. And as a result, the information in the dashboards is mainly used by practice facilitation coaches in order to identify patients for discussion in team case conferencing. So many learnings from these case studies can be applied to the Ontario context and OHTs. So first off, we found that practically applying population segmentation requires integrated information across the continuum of healthcare providers, along with socioeconomic and demographic data. Second, segmentation approaches that have face validity with clinicians and patients will maximize value by ensuring that the system is actually used in the delivery of care, as well as within the organization overall for health system planning that meets the needs of the patient population that they serve. Lastly, population segmentation is a tool within a number of equally important tools and strategies required to help achieve population health management. That's the end of part 3, and I'll thank you very much for your time.
That's great. Thanks, Daniela. And appreciate even we had to call you out on being soft-spoken, but you've got great content and a lot of really important learnings. And Daniela and I had the pleasure of doing interviews with some of these different programs and systems around the world. And it was very enlightening to hear, you know, many years in, they're still working hard, still with wins and still with failures. And just thinking about, you know, what are the enabling features. And so I think you're going to see some of these examples around again in the future, I suspect, both from us and from others, as cases that we can learn from and share. And I think we'll also be doing a little bit of learning here in Ontario as we move in this direction. Again, you know, thinking a lot of these programs have been working on this for quite a bit of time. But we wanted to really pick out those places that were at the leading edge in the world. Okay, so I want to catch a little poll here, and then around, you know, where you're moving in building population health management capacity in the OHTs that you're most familiar with. So I worded it that way this time so that we can have most of the participants, even those that are not directly involved in the OHTs implementation. And so here's the question around where do you think the priorities are for building capacity? Is it around data? Is it around clinician engagement? What about patient and caregiver engagement? Or do you feel that you have most of what you need? And you can click more than one here. And you just need to apply things and take the time. Okay, everybody's hot on the trails here. We're just passing 100 respondents. It's like a little bit of a race. I can see the bars moving up and down, tweak. It's it's going to be an interesting finding. Not tremendously overly surprising, I think, but here we go. I'll leave it out. People are still in. Slowing down. Okay, it's slowed and we're at a minute. So I'm going to end that poll and share out the results. And everybody can now see that it is pretty uniform across these different options, except for the last one of thinking that we have what we need and just to apply, which is a lower response rate there. But 50 to 60% saying we need to be doing all of these things. And I'm glad that you think so, because when we look at these other programs, that is something that we have really found, is that the ones that are at the forefront, and they do it with different strengths. I think we've highlighted, the data capabilities in Kaiser, the relationship and engagement focus, and they do a lot of citizen and patient engagement in the Netherlands as well. Thinking about the quality improvement supports that are available in Jönköping. So it's been quite good. I am to learn so much. So thinking about your adopting segmentation approaches and the extent, what are you trying to do? How are you working? And where are your initial focus populations? And are you exclusively focused on these initial populations, or have you already started to think about some of your future populations? Earlier on, somebody indicated, a second population being brought to them around COVID and mental health and addictions. And so have you even thought also about how focusing on COVID-19, in fact, the people at risk for COVID-19, they're also a priority population for population health management. So in some ways, this is being thrust upon us, I think, at the same time. So I'm going to pick up on some of the comments now that we're seeing. Feel free, please keep adding your thoughts of how you're thinking about choosing populations and where you're focusing activity. There was a comment a few moments ago from Phil Dalton around using practice facilitation support on the use and interpretation of dashboards, and that's currently happening in Southwestern Ontario. So Phil, I look forward to maybe you could, if you have specific examples, or maybe people can follow up to learn a little bit more about that, or you can follow up with us and we can help highlight that. Lorraine Sundstrom Mann says that one of the priority populations in our OHT is children and their families and caregivers living with medical complexity and technology dependence. Some others here, Amber Alpha Bishop, focused on people living with advanced COPD and CHF at risk of institutionalization and building our process so we can replicate for other populations. I think that really is the way to be thinking about this. And some examples we've seen where people explicitly pick out their most complex populations. I think it was Carolyn Steele-Gray was telling me the other day that by solving their most challenging populations, people can then translate that learnings across to others. I'm seeing here, Mike is highlighting some common areas of population focus. So East Ottawa also looking at COPD. North York, Toronto Health Partners focusing on getting information from COVID-19 as part of our health equity working group. I think that's a fantastic idea, Leela Prasad. Thank you for talking about that and mentioning that. Helen Cooper focusing on elderly living independently in naturally occurring retirement communities. And I know that some of the common communities naturally occurring or other types of apartment dwellings have also come up in, it's an emerging issue, I think, different forms of residential care. So we are going to have just one or two other last little comments. Helen Lung agreed the population risk for COVID are in fact priority populations and reflecting the issues of social determinants and health equity issues. Wendy Jerry Hamilton focusing on frail older populations from congregate settings, as well as mental health and substance abuse from congregate settings. So again, that housing as a locality and brings in other questions and issues and challenges. Okay, we're going to leave it up for just a few more minutes. Keep your chat running, and I'm going to move on because that was kind of some of the parts that we had to say from our review, and there will be 3 reports indicated coming out through white papers. We'll make sure that you know about them. And so what are we going to do with this? Is it just 3 parts? No, actually, there's going to be a 4th part to this too. And the purpose of part 4 is to demonstrate what segmentation looks like in Ontario health teams. So I think that sounded like a fun thing for us to be able to do, and a fun thing to be able to show you. And I hope that stay tuned for an early summer release. And we'll be coming back here with knowledge looking ahead. So that's it from our end. And I'm going to turn it over now to hear from Dr. Rob Reed and it's flipping back on me, sorry, Mike and Marsh from RISE. And they're going to talk us through how they are supporting population health management, getting from here to there. So go ahead, gentlemen.
Thank you very much, Walter, and I hope you can hear me okay. Nice to see everybody virtually again and see all your names coming through the chat line. My name is Rob Reed. I'm the Chief Scientist at Trillium Health Partner. I'm also one of the co-leads of RISE and helping putting together the population health management supports for all of you as you move on this journey. I'm also joined today with Mike Hindmarsh, who is our lead coach. And we now have 5 coaches in the field that actually help the Ontario health teams think through all the population health management steps as we go forward. So the purpose today is really to describe some of the supports that RISE has and will be providing to you in your learning journey. And Walter is entirely right here. This is a learning journey for us in Ontario. There are basic approaches that all health systems that deploy population health management have in common, but the ways that they do them are very different. And we're going to be developing our own frameworks, our own ways of doing these in Ontario, and we're going to learn together around these. So this is what RISE is there to help, is for you around the specific learnings in your OHT to apply these concepts. And I just wanted to call out, thanks to Walter and colleagues here, just really tremendous presentations. And I think you get a glimpse as to what an integrated health system that uses management of a population, a full population, will look like in the years ahead in Ontario. And it's an exciting future to get there. There are a lot of changes that need to happen and many investments that need to occur, but we're well on the way with Ontario health teams to getting along this journey. So Walter, I think I'll ask you, I think you're in charge of the slides now. I think I'll just get you to move the slides. These are the learn.
Rob, can you either bend down or turn your camera up? We can only see half.
Okay.
Exactly.
You can only see me a bit. Can you see me there better now?
Yeah, no, that's the better half. Thanks.
That's the better half. Thank you, guys. It is the trouble with Zoom, isn't it? So we're providing 3 main supports to Ontario health teams over the next year. First is some webinars, much like this webinars, and it's going to tackle the concepts and the issues one by one and help Ontario health teams learn these concepts and principles and how to apply them in the priorities on priority populations ongoing. We'll be holding these webinars monthly, and they're open to everybody. In addition, we have coaches, and Mike is with us today. Mike is one of our coaches, and he and the other coaches are assigned to each individual OHT to work with you around coaching, around developing your population health strategy, and all the things that we're going to be working on in the next year. And then in addition, we have virtual collaboratives, where this is a facilitated discussion by priority populations to share our learnings There's a lot of different approaches in Ontario right now. Many people are doing, taking slightly different approaches, and we're going to share and we're going to learn together around how to do this. And these collaboratives will be happening monthly for about 1.5 hours. In addition, we have online discussion sites for us by priority population to share learnings and to work between these sessions. Right now, the coaches are working with the first cohort of the OHTs, and a few months from now, they will be working with the second cohort of the OHTs as well. These are what the learning supports that we've designed by RISE will help with. And they reflect Walter's 6 steps. We've consolidated down into 4 around the capabilities that need to be built to actually have robust population health segmentation or health management. The first is around segmentation and the identification of needs, risks, barriers to care. The second is really around co-designing care models, care pathways, service mix, co-designing with patients and with families around these variety of different segments. Third is actually how to implement, how to make sure that they reach the entire population that they're intended to reach. And then fourth is all about quality improvement and how to continually improve and learn our journey. And our intent here is to meet OHTs where you are in this journey. Everybody is at a very different place here. Some of our OHTs are fairly advanced already in this thinking, and some this is they're very in an early state, and that's fine. We'll help along the way. If we think about the Ontario populations, or the Ontario health populations that you're all now trying to manage or responsible for, we think about the OHT attributed population. And I'm going to bring back this diagram, this pyramid that appeared, that Daniela showed for Denver Health a few minutes ago. And this pyramid represents everybody in your attributed population, from healthy to the sickest people in your population. Okay? People in the population that you're accountable for have common needs and different needs. And the first step is really now to segment the population so that we can design the care models for different segments of people. Okay? This is just the reflection of the Kaiser risk pyramid. You've seen me present this before, and it is another depiction of the Kaiser Denver Health model you saw a few minutes ago. And this is the idea here is we're trying to now divide the attributed population into groups of people so that we can actually proactively manage their care. Okay. Next slide, Walter. And as we go up this pyramid, the needs for care increase, particularly in care management and care coordination, but so do the risks, the barriers, the complexity of care. So it becomes more complex around organizing care the higher you get in the pyramid here. Okay. Next slide, Walter. Now, this is just some examples of some OHT, a few OHT in terms of the priority populations of where they've selected along this pyramid. And some have selected, for instance, institutionalized seniors. So they're looking at seniors in nursing homes, and often at this at the higher or not, or at the moderate level. But other seniors float throughout the whole population. And so over time, the idea is while we start developing the capabilities in the institutional seniors, we will develop these and gradually expand them to other parts of the population. Here's another example of what an OHT, several of the OHTs have done. They have selected, we're going to work with persons with mental health and substance abuse disorders. And you can see that these people range from people with relatively minor mental health conditions to often the most ill people in the most complex groups. So within that priority population, we begin to think through how we might segment this population with mental health and substance use disorders into groups of people with common needs. Okay, Mike, I'll hand this over to you.
Sure. So the next poll question is around how you're segmenting your population. So what we'd like you to do is just pick one of these, I believe. I think you can only pick one, but which best describes the focus of your efforts. One, working across all segments of your population, the whole pyramid that Rob just showed. Working with more than one, but not necessarily all segments. Working within a single segment, or working within a subgroup of a single segment. So maybe you've picked even a subpopulation inside a segment. And then we can see the last item there is it really depends on COVID. So please go ahead and vote, and we'll give you about 30 seconds or so. Walter, I'll just let you cut it off when it makes sense.
I will. So just about 5 seconds left. It's slowing down a bit. We have more than 100 respondents so far. So just about coming up, and I will end it now and show up the results. Can you share those, see those, Mike?
Yeah, I can. This is not completely surprising. So when I've talked with a number of you, as you've taken on coaching, we've seen that, and the other coaches have too, that you are working on more than one segment, but not all at once. And that's completely fine. It makes much more sense to bite off a chunk of the population that you can work with, so sort of keep the teeth metaphor going, cut your teeth on a smaller segment and then think about how you're going to broaden out to the larger population after you've had success on a smaller scale. So wherever you are at this point is fine. Again, the coaches will just help you if you're struggling with your segmentation issues.
Yeah, and you're absolutely right there, Mike. The plan is that we bite our teeth on one or multiple of the segment with priority populations. We learn the strategies and the techniques and the capabilities that are needed for population health management, and then we extend them over time to additional segments and additional subpopulations, so that over time you reach your entire attributed population here. That and this is a journey that we'll be all on together for the next few years. Okay. Next slide, Walter. When I listen to Walter and Daniela and Muda talk about the terrific review that they did and the white papers that came through, these are the things that resonated to me. That population health management is a core feature of Ontario Health Team's integrated systems. And these capabilities must be learned and built and sustained over time. You don't start at 100 miles an hour. You start at the beginning and you work over time. All population health management systems are designed to deliver integrated care. Population health management crosses individual actors in care, individual components of care, and integrates them. These systems are built on time, so there's a commitment to the long game is necessary. And I think it is absolutely essential that these systems, all of them, including Kaiser Permanente, Denver Health, the Netherlands, and all of the examples here rely on primary care as a cornerstone, that anchor tenant on Ontario Health Team. They all keep the entire population in sight. They keep users and non-users of sight, and they apply care proactively over time. Population health management is not just an IT solution. It is an active management solution to clinically manage people in a particular segment and across a population over time. Population segmentation is a first step in applying a population health management approach after you've identified your population. You have to understand the populations, and the segments have to be clinically and socially meaningful, defined by needs and risk factors, and we might even suggest aspirations by patients and families. They're not defined by who delivers care or where it's received. Over time, we will need investments in data and IT capabilities that cross all of the actors in an Ontario Health team so that we can apply active clinical population health management. That's key, and we're going to need to be able to build that over time. Okay. Next slide, Walter. Okay.
Okay, so again, let's have another poll question. What we're interested in finding out is that of your priority populations, how many have been defined by, and you can choose all that apply, clinical need, social support need, geography, utilization, or none of the above? Maybe about a few or 30 seconds or so to finish. And if after answering the question, you want to chat in other ways that you've been doing it, that would be great. It'd be very helpful for the coaches to see if there's other ways that you're thinking of your priority populations.
Just nearing up to 100, so we'll give it another 10 seconds or so.
Just while Walter's finishing that up, if any of you have not heard about the coaches and would like to be involved in coaching, you can email me or Leslie and let us know what you would like to do. So again, anticipated results. Clinical need is certainly the easiest data to get to, and so that's a great way to do it. For those of you that have social support need data, that's even better. Geography, utilization is fine, but don't get caught in the trap of trying to reduce or try to improve care for only the complex patients and not think about other parts of the pyramid. Because the folks that are high risk are clearly going to roll up into complex care if there's not part of a program to address that rising risk population. Thank you.
Okay, so thanks, Mike. And Walter, I think this is our last slide. This is just some information for the participants today about some of the next steps for RISE in the population health management. We've got another webinar coming up on March 18th around the population health management core concepts. And this one, we're going to be talking about care models and how you actually develop care models, what they need to do, how they need to function for particular segments of populations. And we have upcoming collaboratives, which are forums. Oops, we'll go forward, Walter, here. We have upcoming collaboratives, one next week, which is around segmentation. So what we've been talking about today, and we're going to think through together about how we segment our priority populations into groups with shared needs and understand their barriers to care. And we have another virtual collaborative session coming up in late March or early April. We're still defining the date. And that one will be about how getting together about building care models that reach different components of those segments for your priority population. So please join us. And you can get to all of these things either by emailing Mike or me or Leslie, or going to the RISE website and registering.
Thank you so much, Rob and Mike. And I think it's going to be like just an absolutely tremendous opportunity for everybody to be able to benefit from your coaching and your coach's coaching, and spread across the province as we get along the way. So we have a few minutes here. We had a lot to say. So and there's been such active conversation all the way along. I think it's been really fantastic. But if people have other questions of our panel today, I will be watching into the chat here, and panelists might feel that they can come online and join us in. there's a couple of suggestions, but if you have comments, questions, or thoughts, just overall or specific to any one of our panelists from today, this would be a good time to join in and ask them. Well, I'm going to go back to one that that came up very, very early on. And it was, I don't know if Mirabako Shannon is still on the call. She had a few comments on the way through, but one was around this optimal population sizing around this work. That it seemed that some places, like if you looked at how the Netherlands was moving, that they had worked with their localities and their small regions. And I had indicated at the time something around the needing to have local relationships, but then also if you move into financial, that's where you really need to have larger scope and scale. If you're thinking about population segmentation, I don't know, I will ask the question about, I'll ask the question first for you, Rob, because your experience, and Mike wants to chime in, and then I don't know if any of the other trainees working, Lauren, Danielle, or Moody, remember from looking at the populations that were being segmented, how large they were, just to know that.
Yeah, that's a really good question, Mike. I think that we're trying dealing with two different things here. I think one is around developing care models and care pathways for particular segments of the population. And then what are the overall size of an attributed population that would be needed eventually to be able to fund hold and make sure that we had enough flexibility and money to support this journey. I think it really depends on, for these priority populations about which priority populations you are selecting. If you take the very high end of that population, that pyramid, that's relatively small numbers of people that you actually have to organize for. But as you move down that pyramid, it becomes much larger than those populations, and it becomes that you need many more people involved with it. So it depends over time as to where your priority where you're working in those segments that's most important. Mike, I'll maybe let you respond to that as well.
Yeah, I completely agree. And I think what you always want to do is, regardless of where you start in your population pyramid, you want to keep a focus on the other segments and how the work that you're doing maybe within one segment can be modified slightly to apply to other segments, or do you have to do different programs? One thing I will say about managing the population across the pyramids is many teams are using primary care as the sort of focal point, for lack of a better word, or the medical home is probably what you've heard over time, to manage these populations. Now, a lot of the care might be handled by mental health, or in the acute care setting, or home care setting, not home care so much, but might be managed in other sectors. But if the patients are still in primary care, then that's where they're going to be landing at some point. So when you think about your segments, think about who's going to be coordinating care for those patients across different segments.
Yeah, I think it's a very thoughtful and nuanced response of not just having a single uniform answer to the right number of individuals, right? So it's a little bit about, and naturally different populations will have different sizes. I don't know if there's anything from the review that we could see about I don't know if optimal, but most common sized around populations, people.
There wasn't anything in what I saw in terms of recommended sizing. And that was something that varied across all of the cases we looked at. So for example, in Germany, Gesundes, they cover about 33,000 enrollees, contrasted with Sweden, which covers about 340,000 people. And then I think Kaiser Permanente's Washington division covers even more. So I think sometimes it's easy to almost get caught up or overwhelmed by the size that, this is across Ontario, so about 14 million people. Some of the OHTs, I imagine, are covering a large population, but I think it's important to remember that even if you do have a large population, you don't need to deliver the same level of care and the same level of services to everybody in that population. like you may have a significant percent of your population where it is very much just like touch and go preventative services only. And I think it's also important to note too that while the focus of the case was Kaiser Permanente's Washington division, Kaiser Permanente overall does cover a population of 12.2 million people, and they deliver integrated care across those 12.2 million people. And so that population is quite similar to Ontario.
Yeah, thanks very much. We're almost at time, so I'm going to just make two call outs. First off, thanks for those. R.S. Schnauzer, thank you for putting in the chat, and I just want to highlight this and amplify it for everybody. If you're looking for someone to help you lift things, they have very strong legs because they can tell you the barriers that they've kicked over, the ones they've leaned to jump over, and the ones they're still mulling over. So really calling on caregivers to be part of the work. And I think when we say patients and caregivers, and they are an essential part of our health system. The question we're not going to get to today, and we're going to mull over a little bit and put it off to you guys, is from Laura Rosella, which was how much, and this is the $64 million question, how much does the existing structure of our system help or hinder executing population health management? We will bring that one back when we talk about the segmentation, Laura. I'll put it on a sticky and plaster it right here so that every time I open my computer, we think about that, and other people too. One of the things we can say is that population health management has been implemented more readily in certain contexts, but I think you've seen today a number of a variety of different contexts in terms of the insurance systems, in terms of the competitiveness of the markets, in terms of the delivery organization that have moved ahead. So irrespective of where your context, it's still possible. Thank you to everyone here today, and just close it off with a few final comments here and what's coming up. So you will see that fourth Tuesday of the month, you join us here, and we will bring some good content and you bring the chat. So that's why people stay. What's coming up next today was population health management, OHT improvement indicator results. Yes, we will be showing results in the upcoming months. So stay tuned, come back. I will say we anticipate being fairly popular, and we are likely to move to live streaming, which will be a slightly different platform, but you will still register through Zoom. And you will still come in the same way. It's just when you're actually watching, you will be watching on YouTube with a YouTube chat bar beside you to enable that. So we're working on that innovation, and it's the only way we can get above 500. And we think we have demand for that because we had more than that last month. A couple other things just to know: the central evaluation team is backing all of this work. You'll be seeing them coming up again and again. There are broad resources available. You saw some today from RISE and from HSPN. And if you're looking to sign up for the coaching and the upcoming webinars along with population health management, you do that through the RISE website. The ministry has their own source. And yeah, we've started to populate this space on our website. We now have 7 or 8 webinars up that we've run. And as I said, I'm surprised, but yeah, they've been viewed over 100 times, many of them. These are the 3 white papers that will be forthcoming. We'll let you know when they're out. Some existing evaluation results, more to come, and just stay in touch. Follow us on Twitter. We often announce upcoming mentions. Here is where you'll find everything for the Ontario health teams that we have to share with you. And so without further ado, I just want to thank everybody for coming. We're all involved together in this journey, and happy to take it along with you. Take good care, everybody, and enjoy the rest of your afternoon. Bye-bye.